And the most common displacements or subluxations or positional faults, these aren't big, these are just very small, eighth of an inch type displacements. The most common would be the anterior rotation, the posterior rotation, and the upslip. You can get a downslip. We'll go through this on Tuesday. Very rare. You can get an in flare and an out flare. Again, in isolation, the flares are very rare. Generally, the flares occur in conjunction with the rotation. So with the anterior innominate rotation, you'll get a bit of an in flare or an internal rotation of the innominate. And with the posterior rotation, you'll get a little bit of an out flare or an external rotation of the bone. By itself, in isolation, extremely rare. So our focus is going to be to identify and manage with muscle energy and mobilization those three, which are the most common displacements of the innominate on the sacrum. Anterior rotation dysfunction, posterior rotation dysfunction, and the superior iliac shear or the upslip. So in order to identify these, we have to think about our osteopathic triad. A, asymmetry, R, range of motion deficit, and T, tissue texture abnormality. So we really need to look at the anatomy first to make sense of this. So for today, rather than trying to make a diagnosis, I just want you to start to practice getting data on the pelvis. And then we'll take that data, write down what you find, and then we'll put it together into the algorithm, and you'll come up with a diagnosis on your partner. So the first part of the data collection process is to look for asymmetries of the innominate. We're going to use key bony landmarks. We're going to compare the left to right, anterior superior iliac spine. We're going to compare that for differences in height. Is one superior? Is one inferior? As well as is one anterior versus one being posterior. So you're going to look at the four possibilities. Is it symmetrical? Superior to inferior? Is it symmetrical, A to P, or is there asymmetry? Is one up? Is one down? Is one anterior? Is one posterior? We're going to do that for the ASISs. We're going to turn the patient around, and we're going to do that for the PSISs. We're going to get underneath, in both cases, the inferior aspect of the bony prominence, and again we're going to assess for differences in height, superiorly to inferiorly, and anteriorly to posteriorly. You compare left to right. Okay? I want you to look at the iliac crest as well. Compare left to right, primarily for height differences. They should be level. I want you to see if one side is higher or lower than the other. We're going to look at the ischial tuberosities. We'll do that in prone. But iliac crest height is going to be standing, sitting, and supine. ASIS comparison is going to be standing, sitting, and supine. PSIS comparison is going to be standing, sitting, and prone. And then we're going to add ischial tuberosity comparison in prone. Ischial tuberosities will be very important diagnostically in being able to detect an iliac upslip. That's our main asymmetry that we're going to use for that. I also want you to look at the hips in standing, greater trochs, because with regard to an upslip, we need to know if everything is unlevel, including the greater trochanters, or are the greater trochanters level and the iliac crests are unlevel. Is one higher than the other with level greater trochs? That's important. Because we could have the left trochanter higher, the right trochanter higher than the left, and the right iliac crest higher than the left, and that would speak more about a leg length problem. But if the trochanters are level, that tells me that legs are okay. But now if I find asymmetry in iliac crest height, that points more towards an iliosacral problem rather than a leg length problem. So we need to include the height of the greater trochanters to bring in a comparison of leg length. All right, so standing, ASIS, PSIS, iliac crest. Sitting, same. Lying, supine, ASIS. Supine prone, PSIS, ischial tuberosities. And then one thing we're going to do in supine we haven't done in standing or sitting, we're going to look at the pubic tubercles. There's 3 areas of impairment in the pelvis that you will eventually be able to figure out with your diagnosis and be able to treat. And that is an iliosacral, 1, a sacroiliac, 2, and a pubic symphyseal shear, 3. You'll learn how to detect and treat iliosacral and pubic symphyseal shear now in Manual 2, and you'll learn how to diagnose and treat sacroiliac impairment in Manual 3. So in supine, we're going to add to our assessment of bony landmarks the pubic tubercles in the front. This is all under A. So we'll do that first, and then we're going to get into an assessment of R, range of motion. We have several tests there to see if in fact there's a lack of range. We can't only go by landmarks. We can't only go by alignment. We've developed this approach to diagnosing impairment based upon 3 things. It's malaligned, it's lost range, and there's tissue texture abnormality, spasm, guarding, splinting, trigger points, changes in the connective tissues. This is just the first. Okay. Not chiropractic. We're not just looking at alignment. Bring in the other 2, and then we make our diagnosis. And then we look at the history. History tells us a lot about what has happened. So let's do this on a patient. We need a volunteer. Volunteer. Jack, can we have you come up?